Please start, sir. We are live.
Okay, so good evening, all doctors and all good evening, delegates. My name is Vinay More. I am a group product manager from Zydus. I welcome you all to this BemTalk virtual meeting program, a program on a Bempedoic acid. So today's talk will be on a Bempedoic acid in Uncontrolled LDLc, unlocking concepts and unleashing efficacy. So, to discuss about this topic, today with us we have a renowned doctor, Dr. Sameer Jain. He is a senior interventional cardiologist at Kamla Hospital at Jhansi. He has also worked as an AP in cardiology department at UPUMS and freelancing at Agra and Etawah last 2 years. He has done 2,000 cases independently, coronary angioplasty, radial and femoral. He also has done 200 pacemaker implantations and carotid and renal angioplasties. So he has also presented various presentations in CSI. He has also presented various presentations in API Con. Then he has attended various conferences and NIC as well, and given various publication journals in BMJ, Annal, Heart Views, European Journal of Heart Failures. So without wasting time ahead, I request Dr. Sameer Jain to take ahead to a bempedoic acid in uncontrolled LDLs. So over to you, Sameer, sir.
Hello. Hello, good evening everyone. First of all, thank you, Zydus team, Vinay, Priyank, and everyone involved in this session. And welcome all the delegates, doctors, colleagues, fellows. So before starting this new thing, I just want to mention the first thing. These type of sessions are very informative. First of all, you can discuss them, you can study them, and you can also share the slides, concept, your experiences. Slides you can take from anywhere else also, but you can share your experiences and what are the hopes and what are the problems you are going to face. So let's start this new fancy thing, Bempedoic acid. I think this name has been in market for last 1 to 2 months probably, and I am personally listening this name Bempedoic acid. First of all, this is fancy and this is a little bit different. Means while listening this song, this name, we didn't have an idea that it's going to target cholesterol. It's a little bit, we say it's a little bit seems to be a drugs affecting infection or probably affecting the joints. But when we go ahead and we study its literature, it's quite primitive and it's quite original drug for controlling the this statin, controlling this LDL cholesterol, means cholesterol pathway. Means it is the basic drug which affects the cholesterol pathway. So now coming to the topic, that is bempedoic acid in uncontrolled LDL cholesterol. We are just trying to unlocking the concept and unleashing efficacy. So I just want to, and we all know this thing, all the cardiovascular diseases and all the even cerebrovascular diseases, dyslipidemia is always found to be one of the major concern for cardiovascular events. Not only cardiovascular, even cerebrovascular events. Whether it will be primarily or secondarily. Means as we all know that dyslipidemia can be in the case of primarily, in case of secondary, but dyslipidemia is always found to be a major concern for cardiovascular event. As you can see in this graph, that we can see smoking is in 36% means population attributable risk, and obesity is also 20, but even diabetes at 10, and dyslipidemia is found to be 50. Means you can consider that when we compare all the 9 major risk factors, dyslipidemia has 50% of population attributable risk. Means 50% of the patient out of 100, those who are dyslipidemic are having a high risk or high probability for having cardiovascular events. Okay, so why this point I just want to convey that we all know that from where these statins came into the market. They all come from the primary or secondary prevention trials, cardiovascular trials. Some of the trials are very popular, very famous. I think everyone must have heard it, must have read it, like Jupiter trial. As most of our colleagues, most of the pharma people, most of our friends used to mention it, the Jupiter trial. Jupiter trial. सर जुपिटर ट्रायल में देखिए, जुपिटर ट्रायल में बहुत फायदे दिखाए गए हैं, बहुत बेनिफिट्स हैं. It's a good Jupiter trial, mega trial, escort trial. They have all suggested the 30 to 40, even 30 to 40% reduction on non-fatal MI, coronary death, cerebrovascular event, revascularization. Means they have clearly pointed out that we have to use statin as a drug of choice in cases of cardiovascular or cerebrovascular diseases. So when we came to discuss secondary prevention trial, they also suggest that statins are the drug of choice. Means whether we discuss primary prevention trial or secondary prevention trial, statins come first. Whether we take True White, TNT trial, Ideal trial is quite popular because it includes a patient of MI. This lipid trial, care trial, they all suggested instead of they have discussed different type of statins, atorvastatins, pravastatin, simvastatin, rosuvastatin, but they clearly show benefit of 30 to 40% relative reduction in case of in the reduction of LDL cholesterol. So this has been state of art fact. This has been a standard statement, and statins are drug of choice, no doubt about it. So why are we here? Why are we here? Why are what extra we want to add to this treatment? What extra new things we are here to discuss? So I am going to discuss about two concerns. The management of dyslipidemia is high on priority and statin are first line therapy. What? The concern one is, do all statin users achieve LDL cholesterol goals as per guideline recommendation? The most important thing is as per guideline recommendation. Another concern is how to achieve LDL cholesterol target after maximally tolerated dose of statin. So we are here just to discuss all these things little bit. So now to start, concern one. Where are we? Where are we? Why we are so worried about this LDL cholesterol levels? So now before starting this this slide, I just want to add, because we all say tend to say that just try to keep your cholesterol below 100, below 150, below 120, below 20, below 200. There are specific values, there are specific range for these type of cholesterol, whether it's LDL cholesterol, triglyceride, HDL, or VLDL. They are very stringent. They are getting very strict. It means cholesterol, it means lipids are going, means through lipids are found to be more involved in the process than it was earlier thought. As you can see that when we discuss about relative risk reduction per millimole per liter, means around 38 milligram per deciliter reduction in LDL cholesterol causes 23% relative risk reduction. Can you imagine? 23%. It's very high, very, very high. As you can see in this diagram, also there are colored things that are suggesting the role of statin, role of hybrid, role of AGTY, role of bile acid trend, role of CETP inhibitors also. The majority of the trials are supporting statin, 25 trials. And also some new drugs are coming with PCSK9 inhibitors. They also are promising, but for now, statin are the primary drug of choice, and statins are used to control LDL cholesterol. But the concern is now we have to lower it more, where we have to target it fast. We have to be very aggressive. As you can see, these are the risk, these are the targets. As in 2016, when I think this has been front news, this has been front level of cholesterol. In the case of low or moderate risk, the cholesterol level should be less than 115 milligram per deciliter. In the case of high risk patient, we should try to below 100. Very high risk, we should try to keep it below 70. But in 2019, means 3 years back, in European society, they have reduced it more. They have become more strict about this. Means they said that in case of high risk patient, we should try to lower the LDL cholesterol below 70 milligram per deciliter. And in case of very high risk, we should try it to below 55 milligram per deciliter. It means as cardiovascular risk increases, we need to reduce more LDL cholesterol level. As simple as that. So based on the revised ESC 2019 guideline, that even 3 years back, how many patients do have controlled LDL cholesterol? So there are a lot of studies that suggest that that gives them certain idea, or that's given a little bit of your image that how many patients are getting controlled. This is one of the studies that's conducted in the Europe and suggests observational study and suggests a lipid modifying therapy in primary and secondary care. That's called Da Vinci study. It's very important because 5,000, 6,000 patients around involved that has been given primary prevention and secondary prevention trials also that evaluate the impact of 2019 dyslipidemia management guideline on LDL cholesterol management. We can see in Da Vinci study statin uses in all patient on the lipid lowering therapies, and they are found to that only 27% eligible patients are receiving high intensity insulin. 33% achieve lipid goals with high intensity statin. So you can see that they are really underestimating the things. We are really utilizing the statin, and the patients are not majority of the patients are on statin with the proper doses. So when that is Da Vinci study done in very high risk atherosclerotic cardiovascular disease patients, this also says only 37.5% eligible patients are receiving high intensity statin and 18% achieve lipid goal with high intensity statin also. So basically, they are just reconfirming that statins are there, but I think they are not in proper doses, they are not in proper uses. Statins are there, we all know, but it's not getting proper utilizing, or they are after the using, even we are not getting their levels what we have tend to achieve. So what is the clinical benefit on attaining? Why are we discussing about these levels, about target? What are the clinical benefits on attaining LDL cholesterol levels? This is the another Korean nationwide cohort study that include around 5,000 patients with a history of MI. They have studied the LDL cholesterol reduction reduced from 50% from the MI case. It means the having the MI index MI case, and after reduction of LDL cholesterol more than 50% and keeping it at below 70 milligram per deciliter, they have found that 94% of patients were on moderate to high intensity statin. So LDL cholesterol achievers are 22%. Means even on being on the moderate and to high intensity statin, the LDL cholesterol level achievers are only 22%. So you can understand that even on high intensity statin, only 22-25% are properly managed, properly LDL cholesterol managed. So this is the conclusion that in patient with acute MI, achieving a target LDL cholesterol level was associated by low incidence and reduced hazard of recurrent vascular events. Okay. So this is again proving that something is lacking, something is behind, something is missing, some point is there is some missing link. We have to connect it. These are the endpoint results. You can see when the LDL cholesterol level is below 70 milligram per deciliter, the number of people at risk have been quite reduced. Means it's very important to keep LDL cholesterol level. So management of the second concern, how to achieve. Even after discussing this thing, we have found that on statin LDL cholesterol level are affected, corrected, but not proper, not as per guidelines. Means what yes, even 2019 guidelines say they are not attacking, they are not achieving it. So how to achieve LDL cholesterol target after use of maximally tolerated doses of statin? This is you can see this is very good slide. I must recommend it, and I try to convey it into my practice also. When patient ask, when some colleague ask, okay, even after giving the dose of 80 milligram statin or 40 milligram statin, what percentage of LDL cholesterol you are supposed to be reduced? Then you can see that even on high intensity statin, even a high intensity statin plus ezetimibe, only 65% average LDL cholesterol reduction found to be there. Okay. After the adding of these new two drugs, PCSK9 inhibitors plus high intensity statin plus STM5, they are getting 85% average LDL cholesterol reduction after adding these three drugs. Can you imagine? So the label of this thing is very important. Now now the new player came into the play, that is Bempedoic acid. So what is new in this thing? What is the speculation? What is the fanciness in this product? This is, first of all, this is ATP citrate lyase inhibitor. This is first in class. This is LDL lowering drug. Some of his history, it's a very new drug. Its approval in, I think, 2020, and I think in India it's coming in only in this year also. Only in this year, 2022. There are approved indication are uncontrolled LDL cholesterol level with maximum tolerated statin dose, even with mixed dyslipidemia, familial hypercholesterolemia, high risk of atherosclerotic cardiovascular disease patient, or statin intolerance, or whom statin is contraindicated. Okay, so you can understand that this is going to be game changer in the management of dyslipidemia. The dose is 180 milligram orally with or without food, means food have nothing to do with its action. So as a doctor, as a medical practitioner, we all know this chart. This is very important chart. We must have read it millions of times. The statins are affecting the HMG coenzyme A reductase. Basically, as statins are HMG coenzyme A reductase inhibitors. What is bempedoic acid? Bempedoic acid is acting even on before this HMG coenzyme reductase. This is atrial citrate inhibitor, atrial ACL enzyme upstream to HMG coenzyme reductase. Means it's inhibiting one step upstream to this statin action. Okay. So mechanism is on that particular statin particular lipid pathway, and half life is around 20 means 20 to 24 hours, means you have to give only single dose, only OD, only once orally dosing, and the excretion is through kidney. Basically 70% of total dose is through kidney, 5% through feces, and less than 2% through kidney. Means it's quite free of side effects. So there is no concern with hepatic impairment. There is no concern with kidney impairment. But just we have to monitor hyperuricemia. We have to monitor history of gout. We have to monitor history of uric acid inhibiting drug. We have to monitor the uric acid levels. So this is and so little bit artistic diagram, little bit artistic trial. There are two clear things are going on this bempedoic acid. There is a clear serenity thing, clear tranquility thing. Basically, they are suggesting that when to add bempedoic acid out of statin and when to use statin on this new drug. There are two type of things: Bempedoic acid and clear harmony and clear wisdom. As we saw that they have almost same type of patient, and they are they are both including that statin earlier on. Now, after using this bempedoic acid, they are seeing the safety points. So I'm not going to the technical details into this, but you can just see that there are reduction of more than 18% in LDL cholesterol, more than 14% in non-LDL cholesterol, and 11% in total cholesterol. Even apolipoprotein, where we know although apolipoprotein is an inflammatory marker, is an independent marker for atherosclerosis. As we can see in the clear wisdom trial also, this 17.4% reduction in LDL cholesterol and total cholesterol 11%. And another thing, other two studies, the clear tranquility, clear serenity, patient with hypercholesteremia and statin intolerance. The most important thing, they are statin intolerant. This bempedoic acid added to HTP5, rather statin, and the patient is 270 around, duration is 12 weeks. The percentage of statin patient are 30%. The efficacy endpoint is LDL reduction from 12 weeks. Overall safety found to discuss in 12 weeks. So these both suggest that they both show that clear tranquility trial at mean percentage LDL cholesterol reduction At 12 weeks around 28%. That is after reducing the placebo effect. As we all know, there are some placebo effect in this thing. As we can see in bar diagram, a clear cut green line, 18.4%, 18.4% reduction in LDL cholesterol. Means it's not an alternative to statin. It's an additive thing. It's a smart pick when you cannot use statin. It's a smart pick when your statin is not going to affect, not going to control the LDL cholesterol level. Even in the clear serenity trial also, there are percentage of LDL reduction by this 12 weeks, 21%. So they all just are supporter marker that why you use bempedoic acid, when to use. They all are these three. So now another is a phase 3 trial that going on bempedoic acid or ezetimibe alone or in fixed dose combination. As a patient, those who are on high risk due to ASCVD and familiar hypercholesteremia with LDL cholesterol level more than 100 or multiple cardiovascular disease factor, they all patient added to still background with maximum tolerated doses. So they discussed and they studied that when bempedoic acid with ezetimibe added, there are reduction of 34%, 31%, 24%, even on independent or on or alone therapy. Excuse me. Means they are suggesting that if possible we can add them and they are safe to add. There are no significant interaction have been found. So this is another global CVOT clear outcomes have been there, and this is very important line that even ADA, the American Diabetic Association 2002, mentioned bempedoic acid as a lipid lowering agent in high risk patients. This is a big line, big landmark, a big occasion for this bempedoic acid that ADA supported them and included them as a lipid lowering agent, especially in high risk patients. I can understand because they are high risk patients where we have to target LDL cholesterol very strictly. We have to, the targets are very stringent, targets are very tight. We have to reduce it even up to less than 50 milligram per deciliter. Where bempedoic acid came into the play. The another important thing what I want to discuss about this drug, what I found more interesting on this drug, that is it reduces inflammatory cardiovascular marker also, like it reduces apolipoprotein B. The mechanism is because that's bempedoic acid affect that primarily on the HMG coenzyme A inhibitor. It also affect acetyl coenzyme A formation. It's also affect malonyl coenzyme A. It's finally it's basically hampering the pathway that is going to include that going to start with an inflammation like engulfing of macrophages, like release of IL-1, IL-6, IL-8, TNF alpha. They all are inflammatory marker, means that reducing them, it's try to curtail them or halt them. Means it try to reduce the inflammation there, and even it reduces HSCRP, which is quite popular inflammatory marker, as we all know, after this COVID events and the new young cardiac patients, the HSCRP we tend to use, we tend to quantitate it, we tend to calculate it. Okay. So what this is a different slide that are suggestive of that effect of bempedoic acid on HSCRP level. As you can see in clear harmony, clear wisdom, clear tranquility, and clear serenity trial, that there are clear-cut reduction of 20 per more than 20%, even 32% in clear tranquility trial. It's massive. It's massive for any inflammatory marker to reduce up to that this particular ratio, this particular amount. It's just magical because it's really helping your body. It's really helping this inflammatory the healing process to go on a controlled rate. Now coming after discussing the good point, the pros, now coming to the discussing some side effects. I must say I have not yet used this drug, but I have read it. I have gone through the articles. There are no major side effects. The only thing you have to worry is hyperuricemia, not even gout. But hyperuricemia is found to be there because you can say because it's targeting melanin coenzyme formation, pyruvic acid metabolite. It's just blocking one pathway and increasing the formation of other pathways. So it's suppose it's supposed to increase the formation of uric acid, but it's a good thing that it's not causing the uric acid level up to the mark of causing the gout. Means it's not majorly causing the problem in patient, but in some cases there are found to be swelling and there are found to be pain in the wrist joint, in the knee joint also. One of my colleague has said that there is patient who has even start to treat the who is taking treatment for this gouty things. But this is quite insignificant compared to the other side effects of the statin, which we all know that they are quite liver toxic. ALT, ASGPT, SGLT tend to rise even 4 times, 5 times, and weakness. I must say weakness is very troublesome for the statin patients. Here, weakness is not as such mentioned. The other thing is not some article says that bempedoic acid also predisposes to diabetic. Some new diabetic patients have been found with on this trial. I can say yes, this can be possible because of its metabolic effect, but their numbers are quite less. Numbers are quite few, so we should be very careful before using it, and we should be quite monitoring. We should do quite monitoring when we tend to use it, and we should use judiciously bempedoic acid. To summarize this talk, I can say that uncontrolled LDL cholesterol level is a major risk factor for cardiovascular disease. Statins are the first choice of therapy for any type of dyslipidemia, as we all know. Even after use of high intensity statins, only 70% patients have uncontrolled LDL cholesterol. This line is very important. Even after the use of high intensity patients, 70% of patients have uncontrolled LDL cholesterol. Uncontrolled LDL cholesterol increases residual cardiovascular risk disease by 60 to 70%. So you can say the our motive is to reduce the cardiovascular risk. But even after controlling the LDL cholesterol level, we are not getting it. Even after using the high dose intensity statin, we are not we are not achieving the targets. So, because you can see the uncontrolled LDL cholesterol increases the residual cardiovascular disease by 60%. It's massive. As a cardiologist, I can understand what this 60% means. So we have to be very cautious when we are managing dyslipidemia. So now bempedoic acid is really first in class. It's very new. I have discussed the mechanism of action. It's quite unique and quite primitive, I will say. We have found significant LDL cholesterol reduction up to 18% from baseline as an adjuvant to statin, and 28% reduction in statin intolerant patients. That is important. We have basically we have to consider it primarily when patients are on statin intolerance, where its mechanism of action prevents this thing, and it's quite effective, more effective than when you are using it as a single drug alone. It's safe in simple, mild to moderate CKD patient, as we have discussed, because 90% of it metabolized through kidney, but it's found to be safe in mild to moderate CKD patient. And the most common side effects are hyperuricemia, gout, and some cases have new onset diabetes mellitus also. These are the more important things which should be considered before starting this new drug. So this is all from my side. Thank you all. Thank you for listening to me. Thank you for listening. I just say this is a good drug. This is new drug. This should be given This should be given chance, and it has proved that it has worth the money, worth your time, and really a good upcoming drug, and its future is bright, I would say. Thank you.
Thank you, Dr. Sameer. It was a very beautiful and a very lucid presentation, and there are various questions which are featuring now. So I will directly take you through the questions.
Yeah.
So yeah. So the first question, which is from Patna, from Dr. Santosh Kumar, he is asking that according to you, how low is very low with respect to LDL levels?
Sorry, how do?
how low is very
Okay,
low?
okay, okay, okay,
How
okay.
low is very low
Nice,
with
nice,
respect to LDL
nice,
levels?
nice question, Dr. Sandeep from Patna. Nice question. Basically, Bempedoic acid is an has an special indications before it should be started. When we are not having LDL cholesterol level below 70 in high risk patient and below 15 very high risk patient, we should consider starting bempedoic acid 180 milligram once daily. It means I have not personally used it, but it has been mentioned in an article that it reduces more than 20% what we are getting from statin use. Means statin use, if patient is having LDL cholesterol reduction of 20-30%, it will add to that 30% and it will make 50% for the statin for this patient. Means the patient LDL cholesterol will reduce 50% around. And when we are using it on a statin intolerant patient, it's a super magical drug. It can reduce the levels of cholesterol up to the 40% after the use of 24 weeks around. Means we have to give it at least 3 to 6 months. This time period is very important. So just try. Just we have to try it, and later we gain confidence about this what to do.
Okay.
Next, next.
So there's a few more questions. The next question is from Hyderabad, from Dr. Reddy.
Mhm.
He is asking that in patients with high LDLC who are intolerant to statin, what should be our treatment approach?
Actually, this is quite fussy situation because we tend to use statin always. We have been taught to use statin always. So first of all, it's hard to diagnose where when they are statin intolerant. If you have really found them statin intolerant, then I must say we should start considering fibrate controlling drugs as well as PCK9X inhibitor plus bempedoic acid. I'm not supporting only that you should start only bempedoic acid. We should try to combine it with PCSK9 inhibitors or fibric acid inhibitors like this ezetimibe. After addition of these drugs, we can find the optimal target level of LDL cholesterol and triglycerides. So my approach will be because I have not used the drug. I have when I find any patient and certain intolerant, I always prefer PCSK9 inhibitor plus HTMI. They are difficult to control, but reasonably they get controlled. But after the introduction of this drug, I think it will be better. It will be relatively easy to control this type of patients.
Okay. So the next question is from Maharashtra by Dr. Sharma. He is asking that how suitable the bempedoic acid is will be for Indian population when
Yes,
statin is the first choice for Indian dyslipidemia.
yes. This is very good question. Why very nice question. Even this question I have to ask from this company makers. They are expert. How suitable is it for Indian population? How suitable? Because Indian population are quite different. The Indian dyslipidemia is totally different. What we studied in this AD in this trials, in ESC trials, in this ACC trials, the European, American, England, they all are quite different from Indian population. So I would not answer this question. Rather, I would gain from it my practice. I would collect the experience from my colleagues, even from you too. Then I would answer this question. I cannot say how it going to affect our Indian population, but for me, I would not start it as a single drug now. In coming time, I would try to add on this drug to one of the statin or one of the PCSK9 inhibitor. After seeing the response, I will try to start it as a single drug. But for me, for now, I would wait for the reviews to come, for the experience to gain up, and for more articles to support it.
Okay, so there is one last question we are having from Hyderabad once again. So the doctor was asking, would you consider bempedoic acid is going to be a poor man's PCSK9? So it can we replace this
Yes,
PCSK9 with the bempedoic
yes, yes,
acid?
yes. I have a strong belief because PCSK9 is very costly, even not easily not available, even not accessible to the major cities also. Even I think we have to call the company person who deliver this drug to the patient to the hospitals. I must say this is quite early to say, but this drug can be poor man's PCSK9. This drug can be poor man. Rather, this drug can be a poor man's statin. Poor man's first drug that is free of major side effects. I must say.
Mm. So with this, we come to the end of this session, Doctor. So first of all, thank you, Dr. Samir, for giving us your time and for giving us such a beautiful presentation on bempedoic acid and to clarify the new dimension in uncontrolled dyslipidemia. So I thank you very much, Dr. Sami, for giving a very wonderful talk on this bempedoic acid, unlocking concept and unleashing
Thank
efficacy.
you, Vinay. Thank you,
Yeah.
Writers team, and even we are happy to be part of this session because we have learned a lot by this also. And this drug, well, until we learned it, how can we use it? We have to know about the drug. And only then after then we can use it.
Yes.
Okay,
Thank you,
thank you,
doctor. You're
thank you,
welcome.
thank you.
So in future, we'll get connected and we'll continue this such kind of sessions
Yes,
for the uh, medical benefits
yes.
and to upgrade the medical knowledge as well. So
Thank you.
thank you all delegates for giving us a time and have a great evening and have a great weekend. Thank you.